morning, everyone. Welcome to our grand round. Today, I'm honored to present to you our today's speakers. So we have Dr. Joseph Sadek. Dr. Joseph Sadek will talk to us about adult ADHD. Dr. Sadek is a medical doctor. He has also a master in business administration. He has a bachelor degree of pharmaceutical science. He also a diplomate of the American Board of Psychiatry and Neurology. Dr. Sadek is a distinguished full professor of psychiatry at Dalhousie University. He serves as the clinical and academic leader for Nova Scotia Health Acute Care and directs the Atlantic ADHD Center in Nova Scotia. Additionally, he leads the psychopharmacology consultation service at Nova Scotia Health. Dr. Sadek chairs the Education Committee of the Canadian Psychiatric Association and sits on the Royal College Subspecialty Committee in Psychiatry. He has previously served as Vice President of CADRA and remains an active member of its advisory board. Dr. Sadek completed his psychiatry residency at Dalhousie University and followed by psychopharmacology research training and global clinical scholar research training at Harvard University. He is also an editor for Brain Science MDPI journal. As an author, Dr. Sadek has published 5 books and 76 academic papers. His work has been recognized with numerous awards and grants, including honors from the government of Nova Scotia House of Assembly for his contribution to suicide prevention. And an award of merit from the Commonwealth Judicial Institute for his service to the judiciary community. Additionally, he received Education Award in 2023 and 2024 from Dalhousie Medical School. So, chers collègues, please join me and welcome Dr. Sadek. Dr. Sadek, thank you for accepting the invitation. Welcome to Montreal, and the stage is yours.
Thank you very much, Dr. Ibrahim. I am honored to be here. Thank you for inviting me. And I have to say the topic is difficult, and I'll do my best to cover some important areas. Before I start, I want to mention that this is my disclosure statement. This is some of the book royalties for the 5 books I published. Today, I am hopeful to describe some steps of the diagnosis and management of ADHD and some aspects of stimulant abuse, misuse, and diversion. This is a public health concern. We should be all worried about diversion, abuse, and the misuse of medications. And I think we are at a time when this is happening quite, frequently sometimes. And so we need to talk about that. The topic is difficult for many reasons today in 2024. First problem we have is that there is a demand for diagnosis. So physicians are asked more now to diagnose ADHD. They are requested to diagnose ADHD. There's a pressure from social media telling people, the symptoms of ADHD, and then they come to the clinic, they request or they demand an ADHD diagnosis. So it's becoming very difficult that way, that a lot of people are convinced that they have ADHD, and sometimes they don't. There's also a significant influence from pharmaceutical companies. They influence the guidelines, the research, the conferences, and it's quite unfortunate. So there is lack of research in many areas in ADHD.
So the first 42 cases were described by George Still in 1902. Then historically, we have minimal brain damage, minimal brain dysfunction, hyperkinetic reaction. 1980 is a DSM-3. Then 1987, we have DSM-3R, 1994 DSM-4, and then DSM-5. In general, the trend of inattention continues, hyperactivity, impulsivity decrease, recognition of comorbidities increase. I want to touch base on epidemiology and etiology. It's ADHD is the most common psychiatric disorder in childhood, about 5 to 12% of school-aged children. 80% of children with ADHD will continue to meet diagnostic criteria in adolescence. 60% will maintain core symptoms into adulthood. Male to female ratio is about 3 to 1. ADHD, as you know, is neurodevelopmental disorder understood at large by biological mechanism. We have etiological factors, biologically, of course, genetic, CNS insult, neuroanatomical, and we have also some contribution to environment. Genetics, we can look at family study, twin studies, molecular studies, and adoption studies. ADHD has a significant genetic component. Imaging studies, unfortunately, we can diagnose ADHD through neuroimaging techniques. It's not yet a valid tool for diagnosis. However, we know that brain structure, connectivity, neurotransmission pattern of individuals with ADHD tend to show slight but reliable differences from non-ADHD individuals, particularly in the fronto-subcortical domain. What cognitive tasks are different from normal subject with ADHD subjects? Processing speed can be different, working memory can be different, some attentional tasks, and some other cognitive measures such as rule violation, omission errors, and commission errors. Now, there are other factors that could contribute to ADHD symptoms. Some psychological, environmental, social factors. So the same biopsychosocial model we use. We know, for example, deprivation, stress, family discord, poverty, trauma, exposure to environmental toxins, and other risk factors can be contributing. Very important to understand that we have a risk factor interaction. It's well accepted that the reciprocal interaction exists among different factors. For example, child impulsivity may generate more hostility from parents. It also appears that hostility of parents may later increase the intensity of child symptomatology in a complex cycle of sociogenetic interaction. Therefore, multidisciplinary approach is needed. Impairment in ADHD is quite important. This is an area where we say, is that a disorder that needs to be treated? And looking at the level of impairment that people have, I think it absolutely needs to be treated. From preschooler, we see some behavioral disturbance. School age, we see the same behavioral disturbance, academic problems, difficulty with social interaction, self-esteem issues. Those would continue into adolescence with injuries, accidents, legal issues, starting substance use, smoking, risky sexual behavior. And unfortunately, this self-esteem issue brings demoralization syndromes. I see it a lot in young people, college students, and adults as well. So all of these symptoms continue with occupational problems, self-esteem issues, academic failure. So really the main areas in life gets impacted by ADHD. Social gets impacted, academic gets impacted, and work gets impacted by ADHD. As you can see, one of the old Berkeley slides where you can see the difference between ADHD and controls in teen pregnancies, substance use, arrests, stealing, not completing high school, failing grades. Would that be relevant? Absolutely. This is important. In terms of family problems, there is decrease and work problems. We know that there are decreased work productivity, 70 to 80% underperform at work, more working days off work, more impulsive job changes, more divorce, poor parenting, a lot more traffic violations and accidents, traffic violation, speeding, drunk driving, license suspension. Now, diagnostically, how do we diagnose ADHD? This is a very tricky area where a lot of the symptoms are subjective. However, we have a DSM diagnostic criteria specify that we have to have at least 6 symptoms in children and adolescents, 5 in adults, and those symptoms must negatively impact social, academic, and occupational activities. We should have symptoms before age 12, and it should impact at least two domains. So it can't be just at home, it can't be just at work, it can't be just at school, it has to be in like home and school, for example. So two domains. Um, the first area, which is failing to give close attention to details or making careless mistakes. Then we have difficulty sustaining attention, not listening when spoken to directly because the mind is somewhere else. They start the projects, but they don't finish them. And they have difficulty organizing tasks and activities, avoid, dislike, reluctant to engage in tasks requiring sustained mental effort, losing things, easily distracted, forgetful in daily activities, and the hyperactivity, impulsivity, I'm sure you are aware of it, and you can see a lot of it: fidgeting, leaving seats, feeling restless, loud, on the go, talks a lot, blurt answer before questions finished, can't wait their turn and interrupt others. I have a mnemonic for the inattentive symptoms, which is details off. So D stands for details, E for easily distracted, task avoidance, the TA, I for instruction, missing instruction because not listening when spoken to directly, L for losing things, S for sustaining attention, and then that's the word details, then off for or O for organization, F for finishing task, and the other F for forgetfulness. Diagnostic accuracy improved by including longitudinal course, family psychiatric history, having reports from others, collateral information. And this is becoming very difficult to get this collateral information in adults. And going back to report cards is also quite difficult in adults. And you have to have two settings, some symptoms prior to age 12, and you have to have impairment in functioning. Some people would add a continuous performance test. They call it continuous performance test or continuous performance task, CPT. More commonly used CPT, we have the integrated visual auditory CPT, IVA. We have the TOVA, which is test of variable attention. We have Connor CPT-3, which is, all of them are actually can be useful to a certain degree. I'll explain to you why. So those tests, they have an area of high demand and low demand. High demand section, you have the target presented frequently. So for example, you get you have the same target gets presented very frequently. So this creates continuous response set. When the test taker is suddenly presented with, they may find it difficult to put on the brakes. So they keep clicking. So this is the errors of commission or impulsivity because they can't put on the brakes. They keep going on the same task. So that's very much the error of commission or impulsivity. Now, if you give them a boring, low demand section, you see the errors of omission or inattention. And the targets are presented infrequently, and the test taker is likely to lose focus, drift off, so they miss targets when it appears. There are several attention primary scales, but we care about the vigilance particularly. So your ability to do well at the beginning of the test, similar to the end of the test. Deficit in vigilance result from errors of omission. There's also the speed and the focus. In response control, we have the prudence, which is measure of impulsivity, number of errors of commission, reflects the ability to inhibit response to non-target auditory stimuli. There is also consistency scale to ability to respond reliably, and the stamina. Do you get tired during the test? So you fade the mental fatigue after some time on the test. That shows the stamina. Those are, very interesting stuff, and I use them all the time. The one also interesting part is that you have a mean score that's for all of these groups, and you have a standard deviation. As you know, 2 standard deviation means 95% of the population. So imagine if a mean score of 100, standard deviation is 20, So 2 standard deviation means a score between 60 and 140 captures about 95% of the population. So a score below 60, then that would reflect extreme deficit. So that can be a little bit helpful. It's not diagnostic, but it can be helpful. Now, can CPT diagnose ADHD? We have this lovely systematic review and meta-analysis that was published in the American Journal of Child and Adolescent Psychiatry. And basically what they looked at, they pulled the area under the curve, sensitivity, specificity of 3 commonly used CPT subscales: omission, which talks about inattention; commission, which reflects impulsivity; and the total number of errors on the ADHD subscale. So 19 studies used, and best results were for the total ADHD score, followed by the omission, which is inattention score, which is actually very helpful, and the poorest was the commission or impulsivity score. CPT is continuous performance test. So I see a question on the screen. Basically, one of the tests, for example, of the CPT is that you get presented with, you click the mouse if you see number 1 or if you hear number 1. So if any other number comes on the screen, you don't click. If you see 2 or you hear 2, or if you see other 5, 6, any other number, you don't click. You only click if you see the 1 or hear the 1. And that's the test would last for about 20 minutes. And believe it or not, it's quite difficult. It's not that easy. And it's a very interesting test. So that is the CPT which I'm talking about. At clinical level, CPT as a standalone tool have only a modest to moderate ability to differentiate ADHD from, this is the conclusion of that meta-analysis. At clinical level, CPTs are as a standalone tool have only modest to moderate ability to differentiate ADHD from non-ADHD samples. So they should be used only within a more comprehensive diagnostic process, which is exactly what some people do. So we don't rely on ADHD on CPT to diagnose ADHD, but it's very supportive of the diagnosis in many cases. Now we talk about ADHD comorbidities, because comorbidity is the rule rather than exception. 87% of kids have at least one comorbid disorder. 67, they have 2 comorbidities, and 77% of adults meet criteria for comorbid condition. Common comorbidities, we have an anxiety disorder, OCD, SLD, specific learning disorder, mood disorder, either unipolar or bipolar, substance use disorder, alcohol use disorder, borderline personality disorder, antisocial personality disorder, brain injury, and sleep disorder. We ignore obesity and ADHD, but we have a lot of recent data about obesity and ADHD. There are elevated rates of obesity found in both clinical and epidemiological samples in adults and adolescents and children with ADHD. This association persists even after controlling for gender, diet, activity, socioeconomic status, and psychiatric comorbidities. Can you think of anything else you wanna control for in your models, on your statistical models? I think it captured a lot of it. This is very, very important information that, looking at this, rates of obesity found in both clinical and epidemiological samples in all age groups, basically. How do we treat ADHD? We first want to clarify the diagnosis. We want to make sure that one of the diagnostic criteria that it is not secondary to GMC, secondary to general medical condition. and we want to assess psychiatric and medical comorbidity. Sometimes the symptoms could be due to thyroid dysfunction, sleep apnea, all kinds of other symptoms that could, produce symptoms similar to ADHD, and it's not ADHD. Setting patients' goal would be very important before we treat, because when we don't, some people are frustrated and they, um, feel that they didn't get any benefit from treatment. So what ADHD symptoms or behavior do you find most troubling right now? What things would you like to be different next time you visit me? What would be acceptable response to treatment look like? What would you consider a good response? Ask the patient what both acceptable and ideal improvement look like. If they are not sure, suggest some appropriate goals. Document the goals in the chart so you can refer to them over time. The treatment multimodal, of course. So we need to consider their sleep, their nutrition, exercise, and psychoeducation, stimulants and non-stimulant medication, treatment of comorbidity, and psychosocial intervention. Psychosocial intervention, we have CBT, we have physical exercise, mind-body intervention, caregiver intervention, which is parent training, school-based and executive intervention, psychoeducation, social intervention like social skills training, anger management, parent training, and educational and vocational accommodation. Now, the question for you, is there any evidence for any of these? Do you think there is evidence for some of these treatment? We recently found that there's evidence support for cognitive behavioral therapy for adults, caregiver intervention for children. The rest is a work in progress. This is the evidence we have so far. Okay? So this publication is called Psychosocial Intervention for ADHD. I'll leave you if you want to look at this meta-analysis and systematic review. Pharmacotherapy with ADHD is important. We have stimulant medication and non-stimulant medication. We have also newer medications in the pipeline. So we want to start with a long-acting medication. We want to optimize the dose. 40% of people might not respond to one class, they respond to the next class. Optimize the dose and consider adjunctive therapy, and reconsider your diagnosis if all of that is not working. We want to have an optimal level of catecholamines in the prefrontal cortex. We don't want to be over-aroused or under-aroused. As you know, we have the norepinephrine and dopamine. Norepinephrine alpha-2 postsynaptic, engage in alpha-2 receptors. When the patient is alert or interested, regulate attention, behavior, emotions more effectively. Dopamine, suppress the noise, reduce the noise, suppress irrelevant information, reward neurotransmitter. As you know, I'm very sure you are very familiar with these things. Atomoxetine is an NRI. Guanfacine is an alpha-2 adrenoceptor agonist. It's not a psychostimulant. And psychostimulant increase methylphenidate amphetamine, blocks the dopamine and norepinephrine transporter in the prefrontal cortex. Amphetamines also increase the release of dopamine, norepinephrine in presynaptic vesicles, and that reduces the clearance of dopamine in the prefrontal cortex. Could symptoms predict response? So if you come to me with a group of symptoms, can I say, okay, yeah, you will respond to this medication, or no? The answer is no. Symptoms would not predict response. There is a nice chart that is available with all the ADHD medication that you could refer to and have it in your office. Augmentation strategy, you could add a long-acting, you could add a short-acting. However, I'm very worried about short-acting. They have a much higher street value. They get misused or abused. So that's, you should be very careful. A stimulant plus atomoxetine, you need to lower the dose of both. And stimulants and guanfacine can be helpful, or stimulants and clonidine in adults actually can be very helpful. And you can also suggest stimulants and bupropion. When you consider atomoxetine, it's a non-stimulant, it's an NRI. People who don't respond to stimulants, or there is significant adverse effects of stimulants, people with Tourette syndrome, chronic motor tics, comorbid anxiety can be very helpful, people who are worried about abuse and diversion, and as an augmentation strategy. Now, I want to talk to you about this very interesting study. It came from Sweden. Long-term tolerability and safety of pharmacological treatment of ADHD. Because a lot of people wonder, how long would people keep taking medication for? What happens after a couple of years? And so we have this interesting study. It wasn't many people, unfortunately. They started, I think it was 168, but they ended up with 112 for follow-up. However, I think that the results are very interesting. Those are the researchers from Sweden. It was published in the Journal of Clinical Psychopharmacology in 2018. But I think it's a very, very important study. It's a 6-year prospective naturalistic study. So they followed those 168 adults. They were only, after 6 years, they only had 112 that they continued to follow. And here are the results. 57 patients, 51% were still on treatment, 49% discontinued. So basically, half of the people actually stopped the treatment. Probably clinically, you would see very similar picture. Why did they stop? Lack of effect, 29%. So about 1/3, they didn't have any good effect. Very interesting that elevated mood and hypomania were 11%. 9% stopped because they had no losing contact with prescribing physicians. I guess in Nova Scotia now we have so much shortage of physicians. I think this number would be a lot higher. We have no family doctors. We have significant shortage of family doctors. Decreased appetite were 28%, dry mouth 24%, anxiousness, restlessness, increased pulse frequency 19% each. Those are the most common adverse effects. Decreased sexual desire 17%, and perspiration. So those are the most common adverse effects when we look at adverse effects. I think some people were questioning the anxiety as would people on stimulant have an anxiety? Yes. Anxiety and restlessness is one of the big reasons why people stop the stimulants. Subjects, however, who continued their treatment, they reported increased quality of life, and they had scales to show that, higher level of functioning, and that was assessed really well, and a greater understanding of their way of functioning compared to non-medicated subjects. So people who actually continued the treatment, those 50% who continued, reported some benefit. But if you put this in look at it from clinical practice, you would see that yes, half of those people I see will not be taking medications. We have some warning about psychostimulants. They are not benign. There is risk of sudden death, hypertension, risk of psychosis and mania. That's a very serious risk. Aggression, visual disturbance, peripheral vasculopathy like Raynaud's phenomena, pregnancy and lactation, some warning, severe renal insufficiency, and use of other sympathomimetic drugs. We have tons of other adverse effects like dry skin, dry mouth, thirst, dizziness, nausea, stomach problems, vomiting, sweating, appetite reduction, weight loss, growth suppression in kids, frequent urination, tics, or unmasking of tics, sleep difficulties, mood problems, irritability, agitation, and anxiety, increased blood pressure and heart palpitation. We have a severe cardiac warning, headaches, sexual dysfunction, abuse potential, some rebound. I want to briefly talk to you about drug-drug interactions. So the first one, of course, would be the MAO inhibitors, like Nardil or Parnate, phenlazine, triansopramine, and combination of MOIs and psychostimulants is contraindicated within 14 days of MOI use. So that's one big one. Then methylphenidate inhibits the metabolism of warfarin and other anticonvulsant, tricyclic antidepressants. So, which means that you need to lower the dose of these agents if you are going to add a methylphenidate. Agents that change the pH of the GI tract. Not many people are aware of this significant interaction. So a lot of the long-acting medications, they rely on a change of the pH to release some of the powder. So some of the, say in the Adderall, some of the beads are covered to be released in acidic medium. Some are released to be covered in certain way to be released in more alkaline. And as the pH changes, some more of the powder gets released or the beads gets released. Now, what happens if you change the pH to make it all, the same, the most alkaline pH? So now all the drug will be released at once. You lose the long-acting effect of the medication. That's one. And you also get severe rush of a headache. So when you get a patient saying that they have rush of a headache and the medication is not lasting long, the first question I ask, did you add a PPI or any medication for your stomach? And wow, yes, the answer is yes sometimes. So that can be a very, very important consideration in your drug interaction. Atomoxetine is metabolized by 2D6, the cytochrome P450 2D6. So any inhibitor like fluoxetine or paroxetine or quinidine, that would increase the level of atomoxetine. Now the universal enzyme inducers like carbamazepine or barbiturates would actually lower the metabolism of atomoxetine. So I want to remind you of this tegretol or carbamazepine because it's an important one. Carbamazepine is a universal enzyme inducer, okay? It lowers the metabolism of almost everything. It's like massive. It lowers the metabolism of itself. So if you have someone on tegretol, be very careful with the rest of the meds they are on. And then be careful with the tegretol, the carbamazepine level as well. And the word the carbamazepine, I was looking at this and, it has the first, group has all the universal enzyme inducers. So we have the C for cigarettes, the A for alcohol, R for rifampin, B for barbiturates, and phenytoins comes with it. So this carbamazepine word is the carbamazepine itself is the strongest universal enzyme inducer, but also there's other enzyme inducers involved in this word that to remember it, I use it as a mnemonic. So those would be the drug interaction. We don't have enough data on teratogenicity or breastfeeding. Amphetamines has some degree of possible teratogenic embryotoxic potential. We, the verdict is not clear in terms of lactation. I think it should not be used in lactating mothers. Now, let's talk about the last piece, which is, I think, one of the important pieces. Which is, stimulant abuse, misuse, and diversion. I have a publication in 2022 about that topic, and it's free online. Please feel free to, if you are interested in the topic, you download it. The prevalence of diversion is not really clear, but we have some older studies suggested that rate of diversion is between 11 to 29%. Okay, we know that 8% of students sold or gave away medication. 63 of the students knew someone who had done so, and 67% knew someone who has taken stimulant medication recreationally. So that's a very interesting kind of study in university students. Other studies measured prevalence of students with prescriptions asked to sell, trade, or give away their medication. They found that 23 to 84% of students have been approached. This is a US study, but I think we have a very similar presentation. So our duty as healthcare professionals and parents to monitor changes in the potential for stimulant misuse diversion, which may come with changes in some circumstances and age. Why do people misuse? To improve attention, concentration, to improve study habits, or to get high. There are factors associated with stimulant use. Males are more than females, Caucasian, student with lower grade point average, history of substance abuse and risky behaviors. The very promising to detect malingering ADHD are SVTs. We use SVTs in forensics, but in ADHD, we can use cognitive SVTs. As a matter of fact, in Victoria, BC, they have one of the wonderful SVTs, which is called Victoria Symptom Validity Test, VSVT. Remember that? VSVT. And those are very helpful in detecting malingering in SVTs. Now, if you combine a couple of SVTs, you get a very good ability to detect malingering. And some of the CPTs, the one that I just mentioned to you now, all of them also added a malingering detectors to them. So I think that would be, I think it's a very important area to look at if you practice in this area.